Now, hello and welcome everybody. My name is Jane Clare and I'm the Education Resource Manager for ISQua, and I'd like to welcome you all along today to our webinar hosted by Cliff Hughes, and it is Recognition and Management of the Deteriorating Patient, Lessons from the Beach. So as I said, welcome along to everybody. It's 11 o'clock in the morning in Dublin, so I'll say good morning to you, and wherever you are in the world, I hope you're having a good day or have had a good day. Firstly, I'd just like to remind all fellowship participants that we have 3 questions after the webinar. And if you wish to claim points for viewing the webinar, you'll have to answer these 3 questions in our fellowship forum or in the comment box when you submit your credits. I'll just say a few words about Cliff Hughes just as an introduction, and then I'll pass over to him to continue the webinar. So Professor Cliff Hughes is Chief Executive Officer of the Clinical Excellence Commission, New South Wales, Australia. The mission of this statutory health organisation is to build confidence in healthcare in New South Wales by making it demonstrably safer and better for patients and a more rewarding workplace. For 25 years, he was a cardiothoracic surgeon. He has published over 100 articles and 100 abstracts on surgery, quality, safety and practice improvement. He is passionate about patient-based care, better incident management and reporting, quality improvement programs and development of clinical leaders. So without further ado, I'll hand you over to Cliff. Cliff, are you there?
I am. Thank you for that welcome, Jane.
No problem at all. If you just hold on one moment, I'll make you the presenter so we can all see your screen.
Good. So can you all see that now?
Yes, we can indeed. That's perfect.
Excellent. Well, thank you, Jane, and good morning, good afternoon, or good evening, wherever you are. In contradistinction to the photograph on the screen up the top left, it's 10 o'clock at night here and quite dark. But I want to take you down to this beach, which is one of our famous beaches, Manly Beach, on a sunny day. And you can see there that there are 2 red and yellow flags, and you can see some of the lifesavers with their red and yellow distinctive uniforms. They are found on every beach, and we know that they have saved lives. And what I want to do is take you, more importantly, down to the photo of the right of the patient. Happens to be with a red wall and a yellow blanket by coincidence, but he's lying there with a simple bell button to call for help when necessary, pretty old-fashioned phone, the side of the desk, and not much else around him. And it's these people who fade away silently in our wards that we need to work on. And there are some lessons we can take from the beach and bring to the bedside, which I hope we can explore today. So let's move on then and have a look a little bit at the environment from which we come. As you can see here, Australia is an island continent. It's the largest island continent in the world, made up of a number of states. And it's not surprising with our coastline that there are literally thousands of beautiful beaches right around the country that are very tempting for people to swim in at the first sign of warm weather. Just to give you some idea of this continent, you can see here its size in proportion to European countries, and it is big, but it's empty. Most of the people live around the coastline so they can get access to the surf if for no other reason. New South Wales is the state within which I live and work, and Sydney, as you can see, is virtually the middle of the coastline, which stretches from beautiful Byron Bay in the north right down to our border with Victoria. Surf lifesaving has been a feature of all the beaches down this coast since the late 1930s. Not only has it been a feature, but they've kept very accurate records of their work on the beaches. And it's something we need to remember in health, that we need to keep records of what we're doing if we want to learn. Because one of the things that the lifesavers learned was that they needed to be able to respond quickly and often without too much warning when a swimmer got into problems. And of course in our ward it is the quiet, unexpected and often unnecessary death of a patient that we really have to do something about. These are people that should not have died, and we should do something to help. One of those patients was this young girl, Vanessa Anderson. She was a teenager. She was very popular at school and quite an outgoing young lady who was playing golf with some of her friends one afternoon when she got hit on the head by a ball hit by one of her school friends. And as you can see here, 24 hours later she had died. She'd been through two hospitals, both well-known hospitals with a good reputation. It was a tragedy of the first order. But perhaps the greatest tragedy was that there was a failure for the staff to recognise that she was deteriorating. Her family, however, had a different view. In fact, her father, Warren, was so concerned with her state in the second hospital that he went in the late evening and decided to sleep in the chair in her room. About midnight or so, she had a funny episode which was described to the nurses as a convulsion. The nurses checked her out and said, well, it wasn't so much a convulsion as probably just a nightmare. At 2 a.m, the nurses again checked on Vanessa. They opened the door and they realised that Warren was asleep in the chair and Vanessa was quietly asleep in her bed, and they decided not to wake her when she was obviously so peacefully asleep. 3 hours later, 5 a.m. in the morning, Warren woke up to find that his daughter was dead and had been dead for some time. You can imagine the trauma to this patient. It resulted in a major inquiry. There was a coronial inquiry, and the coroner found that there were a number of contributing factors, the first of which was poor communication between doctors. There'd been inadequate handover between the hospitals. There'd been inadequate communication between the junior staff, the trainee staff, and the consultants looking after her. There were also staffing inadequacies and a number of poor clinical decisions by both doctors and by nurses. And she was given incorrect opiate medication. And the coroner concluded that there were systemic problems existing for a number of years in New South Wales Health. In fact, he went further to say that virtually every problem that could occur in healthcare had occurred in the management of this young girl. So we had a problem, and this is the problem. Unrecognised deterioration is a significant problem for all patients in all health systems, and it occurs despite the fact that we know what are the hallmark clinical signs of deterioration, and that was happening in the best of our hospitals in New South Wales. Could we have saved this patient? Well, there was an even bigger inquiry to follow. Justice Peter Garling, a senior counsel, was asked to investigate not only this one particular case, but the entire acute care services in all our public hospitals in the state. And the first comment that he made was that there was a significant divide between management and clinicians, so that people were not working together as a team. There was a management approach, which was a process approach, a clinician approach, which was outcome driven, but never the two should meet. And he described it to the great schism of 1054, a theological conflict between the East and West orthodoxies of the time, both serving a similar God, but getting it totally wrong in their communication. And Mr. Garling, Justice Garling, felt that the same thing was happening in healthcare in New South Wales, and we needed to do something different. He did this not out of an opinion, but out of a huge report, 1,200 submissions, 61 hospital visits, 39 public hearings, 628 witnesses, 110 other meetings, and numerous private hearings from other interested parties. And he recognised that the problem with this particular case, but the problem with patients in our wards generally, were that we were missing opportunities, firstly, to prevent tragedies from occurring, Secondly, to recognise them as they occur. Thirdly, to escalate to the appropriate level of care and support that clinicians at the coalface might need. And finally, to have a system in which response was there exactly when it needed. We could summarise that another way. I was not on duty. I don't see because I don't look. I don't speak because I'm frightened I might get into trouble. And I don't listen because I don't want to be disturbed. We often laugh at the three wise monkeys, but they're alive and well in so many of our healthcare services, aren't they? At the Clinical Excellence Commission, we had begun to do some work on this issue, and we were preparing some background studies on this issue of failure to rescue. We recognised that there were some other opportunities for us to learn. While preparing a talk on clinical guidelines, I was taking photographs of various warning signs, and I was a beachside suburb and noticed the flags on the beach. I took appropriate photo, which we've used many times since, and I contacted the Surf Lifesaving Association in Australia to find out how effective their flags were. I was surprised to learn that since 1935, when they started collecting the records, only one person had been drowned between the flags on a patrol beach, that is when the lifesavers are present. Only one. And even that patient, there was some confusion. He'd had signs of a recent heart attack, but he had seawater in his lungs and by definition was called drowning. It seemed to us suddenly that our lifesavers could keep swimmers safe despite the very turbulent surf within which even novice swimmers were enjoying their day. How could they do it? And were there some lessons that we could learn for our clinical staff in our hospitals that also have the same currents, undertows and potential risks? What was it that made the difference? The difference was that the whole duty of a lifesaver was to watch, even those swimmers who appeared to be healthy. And to do that, they would define clear areas where swimmers could be reasonably certain there were no sandbars, there were no more channels, and there were no currents. So the flags actually defined a threshold for safety. And the penny dropped for us. We needed to learn to keep our patients safe by keeping them between the flags, where we could watch them and watch for problems before they got into trouble. To quote one lifesaver, if you wait until the swimmer waves their hands, it's often too late. So not surprisingly, we approached Surf Lifesaving Australia and asked them if we could borrow their logos, and we have. We've even borrowed their motto, but we haven't said swim, we've just said between the flags. And they remain very interested in this project because both of us were interested in keeping people safe. And this program is known as Between the Flags, or for short, BTF. The aim of the project was to improve the early recognition and response to clinical deterioration and thereby reduce potentially preventable deaths and serious adverse events in patients receiving care in our hospitals. There are 260 hospitals, multi-purpose centres, hospitals large and small, scattered across the state. And in each of those, we had to learn to keep people safe. It's interesting to note that the further away from the surf you live, the greater risk that when you go to the surf, you will have an adverse event, that is, you may drown. Because people aren't aware and taking care of their own care, and they do silly things like swim outside the flags. And it's interesting to note that people do die on patrol beaches when they swim outside the flags where the lifesavers can't always keep an eye on them. They can die on the same beach that was patrolled during the day because they choose to swim at dusk when there are no lifesavers present and when the currents can be at their worst. So we really needed to find a way to drive change. And the first thing we had to do was to revisit the system and do a diagnostic and understand the underlying issues. So diagnosis of the problem is really critical when we're trying to develop a clinical practice improvement program. The first thing is to understand the underlying issues, and to do that we surveyed a representative sample of facilities across the state, large and small, complex, tertiary referral centres, multi-purpose centres and small district hospitals. And we observed the studies of nurse practice. We used some of the techniques from other programs, the productive ward, the concept of looking at the 5 S's that I'm sure you are well aware of, to see if there was some lesson to learn. We needed to sort, to set, to shine, to standardise and sustain key patterns of work. That's the 5 S's. But we also needed to talk to individuals on the wards, to do focus groups, and to map the processes that they were using on their wards and try and identify what an ideal ward should look like. And finally, when we started to come up with some ideas, to go back to the staff and to brainstorm the way in which we could apply those on the wards. And the first area of concern raised almost across the board was the problem with clinical observations. We did know that observation charts were being used, but we needed to audit them against the criteria that we recognise as indicating deterioration. And there the problem began. And of course we did a review of the literature. We also reviewed our incident information management system data. This is a voluntary reporting system that all staff can access online. And we also looked at root cause analysis reports to see what we could find. The first thing was, it was a significant problem. We could not ignore it. It was as bad in New South Wales as any other jurisdiction around the globe. Second, there are hallmark clinical signs that indicate a patient is getting sicker, and we'll talk about that in just a moment. But they were being ignored or simply not recognised. We also showed quite clearly that we were not escalating care appropriately. If Vanessa Anderson with a depressed skull fracture complains of a convulsion and we don't escalate care, the results become all too painfully obvious. It became clear to us that communication and documentation were key factors. Now, none of the things on this slide are rocket science. None of them are things that require highly skilled technological or even IT solutions. They really lead us to focus on what we are supposed to do in health, and that is to care. So let's actually have a look at what was happening with some of our observations. We decided to review what observations were being taken and documented over a 4-month period, and you can see the months down the bottom. And you'll notice here that for each of the observations there was a significant improvement to almost universal collection of the data with a couple of exceptions. And the really significant issue is smack bang in the middle of the slide. Respiratory rate didn't even improve over the 4 months. In fact, by the end of the study, people were getting used to people observing what they were doing and stopped worrying about respiratory rate. And of course that meant, right on the right-hand side of this slide, that our observations were simply not complete. But more importantly, this flew in the face of what patients were telling us. Parents would tell us that their child was sick because they were breathing very fast. Women were telling us that their old uncle or father was getting sicker because his breathing has become laboured or shallow, or he was struggling to get a breath. So patients knew what the problem was. The staff weren't bothering to measure it. And you know as well as I do why that is. It takes time to measure the respiratory rate unless you happen to be on a ventilator. So the problem was that we weren't using observations in a reliable fashion to either diagnose or to escalate the problem. And if you have a look here at an overview of the entire pattern of observations across New South Wales, you can see again that in the middle we have the respiratory rate. The only thing that was worse than that was the graphing of observations. People were writing observations down, but there was no graphical interface for people to rapidly identify when a problem occurred. So we had a big problem. But that problem wasn't related just to the data. A thematic review from junior resident staff showed some of the issues, and they're all here for you. I'm not going to go through all of them, and we can't go through all of them tonight. Ineffective paging system, though, tells us that it was not easy to escalate. And lack of calling criteria, we've just described how important that was. And the other things just build on those two basic problems at the beginning of a JMO's call to a sick patient. But the nurses also had a similar series of themes when we looked at their focus groups. They complained there was not enough time for direct patient care. There was a lack of reliable equipment. And we had some very interesting examples of where equipment failures delayed recognition of the sick patient whilst people were trying to correct the machines and forgot about correcting the patient. They also noted that there was a problem with disorder, and they recognised that the tidy ward was a much safer place. And so it goes on. And as you can see on the third last dot point, lack of clear calling criteria. Yet again, no common sense that now we must act. So they were the problems, and what were we going to do about those problems? We recognised that the problem was people were going down the slippery slope of deterioration far too far before there was any response. Early on in our observations, we had noticed that cardiac arrest cause, the ALS arrow there, was associated with a mortality of around about 85%. So if we wait for the cardiac arrest or the code blue, the chances of us salvaging people were poor. Fortunately, in New South Wales, a lot of work has been done by a number of our senior clinicians, Professor Ken Hillman, Professor Malcolm Fisher and Professor Teresa Jacques, all intensivists with a very strong interest in deterioration and the physiology of deterioration. And they had introduced the concept of medical emergency teams across Australia, and Ken Hillman authored a very well-known paper on the MERIT study. And that showed that if we had rapid response teams coming to the ward, they could salvage a lot more people, and you can see that here with the red arrow. But there was still a gap between those patients who'd had a clinical review and before anyone had bothered to call for help. So this gap here was exactly what we chose to address with our Between Flags program. There is still a gap between prevention and clinical review, and we'll come back to that towards the end of this talk. So here was where we really wanted to intervene and catch the patients while we had a much greater chance of allowing them to survive. But how to do that? The lifesavers told us. By coincidence, the red and yellow are associated with warning or with danger in most environments, traffic lights for example. We realised that we had to introduce a track and trigger tool. So after extensive consultations with clinicians right across the state, we rewrote the adult observation charts in the first instance and followed that with paediatrics. Because the charts were confused. They had multiple measurements across the one series of graphs. There was no clarity. There was no real sense of trigger. So this is what's now known in New South Wales as the Standard Adult General Observation Chart, or SAGO chart. And it actually consists of 4 pages. And here is the working side of the paper. And you can see here that each measurement has 3 zones: a white zone, surrounded by a yellow zone, surrounded by a red zone. By the way, these colours may not come across to you exactly as red, but they were developed in conjunction with our printers to make sure that these would not affect people with colour blindness, and also if they were photocopied, which we don't allow, there was some sense of shading difference. But you can see we've adopted the ABC approach, so airway, breathing, circulation, disability, in this case neurological deficit, and temperature over here. And you'll notice temperature doesn't have a red zone, because all the physiology tells us that temperature is not a particularly good indication of severe deterioration. In fact, the very hypotensive, shocked, almost moribund patient will not have a high temperature. So this was the chart, which had some areas for other measurements such as pain score and the like, became our standard observation chart. As I mentioned, we used the ABCD approach. We had an area where if the observation was charted, that is in the yellow zone on any of these observations, it was mandated that the staff would call for a clinical review. Usually the first point of call would be the nursing unit manager or team leader, but if necessary, the junior medical staff. And a clinical review would take place. And that would be documented and action also documented. And it may well be, this doesn't look quite right, let's review the observations in 1 hour, not 4 hours. Or no, let's do something more immediately. But if the observations were placed in the red zone, this mandated across all of the facilities in our state a rapid response call to a Met team or otherwise. And that included in small country centres where they'd often call the paramedics from the ambulance service to come and help them while transfer was being arranged to a facility with a HDU or ICU. We also made sure that we maintained the usual standard concerns for absolutely accurate ID of all patients on all pages of the clinical record. On the reverse of the chart, there were the criteria for calling a clinical review or for calling a rapid response, but also some suggestions which can be customised to the local facility to make sure that the appropriate escalation process takes place rapidly. These were tested quite widely across the state and have been university agreed. However, we did recognise that as well as having standard templates and standard patients, there are times when people have other charts in place because they've got specialty requirements, and we needed to know that. So there's a spot here where we can indicate what other charts are being used for patient monitoring. But as well as that, we recognise that occasionally it's reasonable to vary the frequency of the observations. So a person on a respiratory ward with chronic obstructive pulmonary disease may have his observations or her observations taken less frequently because we know they have a tachypnea all the time. And as well as that, we can alter the criteria for calling either a clinical review or a rapid response. This could only be done by a consultant, a senior member of the team, in conjunction with his team, and had to be documented and signed by that senior medical officer. So what were we doing here? We were standardising our response to the deteriorating patient, allowing for additional criteria instructions, but making this chart the track and trigger tool rather than just simply a piece of paper at the end of the ward. But we couldn't take that further unless we engaged with all our stakeholders. And here's just some of them. We had to engage with the clinicians obviously. Don't need to go through that any further. We had to engage with the executive sponsors in our area health services, our local health districts, and our facilities. We had to engage centrally with the Ministry of Health. After all, they were going to provide some of the resources to have these statewide charts, to have the databases and so on to support it, and also to help us engage with patient and family community networks and with the nursing and midwifery office. We need to do some special work with child health networks, and we don't have time to talk about that today, but we have a series of paediatric charts and special charts for mothers at risk after childbirth. But we also had to engage with New South Wales Ambulance, because in small country centres with a multi-purpose centre which might only have a few beds and no intensive care or high dependency unit, the paramedics became the first point of call for a rapid response team. So we really started to move towards a new clinical practice model. And here's just an example that shows you the importance of engaging with all stakeholders. And that is, again, to have a clinical emergency response system which is tailored to the local facility. And New South Wales Ambulance agreed to have a special number so that if somebody rang through on a dedicated call line, the ambulance knew that this was a call from help for a facility and was not something that they should ignore or think was just another routine transfer. And they also needed to make sure that their equipment was compatible with that within the hospital. So how was this going to work? Well, really because we had developed standardised calling criteria and charts. It was simple. It was standardised across the state, so even if our residents, our nurses, our physios and others were moving from hospital to hospital in a 10-week term rotation, they still encountered the same process with the same definitions. All they needed to know is what was the local variation once the call criteria indicated escalation. You'll notice that we put the most sensitive indicator of deterioration first. Top of the chart on the left, where people read first, was respiratory rate. You'll see we've moved away from written observations because people's writing can't be determined. And we graphed it. And we then observed its usefulness and its relevance and continued to evaluate and provide feedback to the system so we can make changes and make the chart more useful. We also spent some time talking to our human factors colleagues about the principles. Top left-hand corner is first, so let's put the first observation up there, not temperature, breathing rate. Let's make sure we've got the font size and type right, and there's quite a science to that which I was not aware of until we started this program. There was no overlap of parameters, there's no guessing where the chart's going because each particular measurement has its own particular box. We talked about colour choice for emphasis and for colour blindness. But we had now a consistent format, we had clear and descriptive labels, and the chart, because of its colour, is actually easier to read in areas of poor legibility. But as well as that, we had to embark on a very serious education program, and this is our DETECT program, which you can see here talks about detecting deterioration, evaluation, treatment, escalation, communication of our teams, and this is truly a multidisciplinary approach. It has a manual, it has e-learning modules and clinical skills workshops. We recognised that there were different levels of training. One size won't fit all in this environment. So we had to tailor our education program across the state. We have 108,000 staff in New South Wales Health. We needed to be specific. Tier 1 was compulsory for all members of staff. This was an e-learning, a very short package of awareness of what DETECT, what BTF or Between the Flags was really all about. Tier 2 was more specific for those people who are going to be involved in the first response and identification of the deteriorating patient. And this focused very largely on the physiology of deterioration, and this program has been led by Professor Terry Jacques from St George Hospital here in Sydney. But Tier 3 was also to train the responders, the people who came on the MET calls or from the ICUs or from the paramedics also needed to know what the problems were. They didn't need to know the physiology, they knew that. They needed to know what the problems were around the escalation of care, communication and documentation. That's not going to happen unless we have a very effective process for change management. And without going into too much detail here, you can see in the middle the 4 components that I've already talked about: the standard calling criteria, the clinical emergency response systems, education, and we'll talk about evaluation in a moment. But it has to be surrounded by effective clinical governance. And this is where the facility managers and the executive teams across our system became crucial. And we could spend a lot of time going through each of the components. But just to say, we've only just started on this journey. It's true now that Between the Flags is part of our culture. Staff talk about a patient being BTF'd, that is on the chart, and having their deterioration recognised. But you can see we have to move further upstream towards prevention. We need to have an evaluation collaborative, which we have in place. We need to reinforce the clinical emergency response team each year when new staff come on board. We have to deal with the age-old issues, but more importantly, we can also engage the patient and their family in this entire process. And we have a program in New South Wales called REACH, which stands to Recognise, Engage, Act, Call, Help is on its way. This is a program that enables patients and their families to initiate that medical response because they are concerned. And we all know when mum says the child is sick, the child is sick. What a pity that we didn't act on that information when we had it right in front of us. And this is a flow chart which will be in your slides, and you can look at that in more detail, and it summarises with just a bit more detail some of the principles of the REACH program. So now the patient and their family and carer are part of the team. And we do have patients who indicate something is not right. And guess what? They're more often right than they are wrong. They're probably better at picking deterioration than are our staff. And we educate them as well, and this is just the front page of the brochure that we give out to our patients in the number of pilot sites that we're working at the moment. But we need to evaluate all the programs. The first was to evaluate the standards for data collection and reporting, to look at the key performance indicators across the state, and get the chief executives of facilities and local health districts to report against agreed definitions. And we've also developed a state database to collect data from the medical response teams and also those performance indicators. And again, we come back to governance, and we had to engage the chief executives. Fortunately, we've had a series of very strong directors general of health who drove the chief execs to drive their executive sponsors, to drive clinical governance, and right through the entire system, and to report back to the peak quality committees of the board, and also to the committees that run our clinical emergency response team. So in quick review, here's the yellow zone. This is the novel bit. This is the bit that people were ignoring. This was the beginning of the sickness slope. Clinical review must occur within 30 minutes of someone being in the yellow zone. It is the responsibility of the home team and requires consultation with senior nurse, but there is room for discretion. The red zone is more traditional. Rapid response systems we all know about. Pre-existing systems such as MET teams were in place. Individual team training around ALS skills were there, but we removed the discretion. If a person is in the red zone, it is mandated that you call for help. Now, does all this work? This is some work from our quality systems assessment program, and we asked the heads of units and nursing unit managers if a clinical lead or clinical champion was critical to the uptake of this program in their unit. Don't worry about the two columns on the right, that's Justice Health and the Ambulance Service. The other one is a combination of the various area health services at the time. And you can see here that there's an overwhelming view that this has been very helpful to the uptake of the program. Clinical champions. What do you think would happen if we asked the same question about management champions? Here's the answer. The clinicians themselves, the senior clinicians, senior nurses, felt that management or executive support was even more important than clinical support. Why should that be? Because management working together with clinicians can really change the world. Management can empower junior staff to get to their training. They can empower production of simple charts and so on. Pity was that we didn't ask people whether they thought a combined executive and management champion team would be critical. I suspect it would be up 95%. We then actually asked people whether or not they thought the program was being successful, and I'm not going to go through each of these questions. You can look at them at your leisure in your slides. But again, you can see that for the majority of the issues, if you put agreed and strongly agreed together, this program is significantly changing the culture of healthcare in New South Wales and continues to do so. So what are the lessons that we've learned from tonight and from our last 3 years of implementation? We need to have executive and clinical leadership. We need a good plan. We do need to use branding in marketing, and in New South Wales, in Australia, the lifesavers are well known. Maybe if you live on the ski slopes in Colorado, you need to think about ski flags rather than surf flags. We need to have partnerships. We need to have governance structures. We need to have awareness and education. And if we have all of those things, we can address the age-old problems. Nurses can now get a response when they're worried. Young doctors who weren't quite sure what to do came when they were being called. The communication within the team was dealt with because of the chart itself. And by actually asking the staff how did the chart benefit them, we dealt with the issue, what's in it for me? safety, security, and better outcomes for our patients. So in summary, Between the Flags has captured the imagination of the staff across the state. BTF is part of the language. Staff believe it's making a difference. And there are good signs that it's reducing cardiac arrests. Since we started, the number of cardiac arrest calls has decreased by 38%, and that number is statistically significant. The increase has been in the number of early calls, the yellow calls, and that's exactly what we wanted to see, and about a 22% increase in those number of early calls, where we can actually fix the problem. And I believe those two graphs are linked together. What did we need to get it done? A vision to see what could be done and what was possible. A plan to make it happen. We certainly need a coalition of willing teams. We needed to use the power of stories and the courage of leaders. We happen to have had all those come together in the Between the Flags program. So back to the beach. The lifesavers have a motto, whatever it takes, and you can see here some of the equipment that they use to prevent people from drowning on our beaches. And there are the yellow flags, a critical part of whatever it takes. So can I just finish by showing you one of the advertisements that Surf Life Saving Australia uses to remind people of the good work that they do, and most of these young people are volunteers. Just have a look at this. So the question is, do we have what it takes to make sure that Vanessa Anderson never happens again? We probably do, but we've got a long way to go. But what we really need is people. And these are just some of the leaders of the team here in New South Wales that have made this possible. And that have saved now, we believe, using trendline data, approximately 980 people in just 3 years. Do you have what it takes? Perhaps we should talk about that. Back to you, Jane.
Wow, Cliff, thank you very much. That was certainly a fascinating presentation, and really an excellent example of how we can develop projects and tools to implement them in our workplaces to increase quality and safety, and really that a figure of 980 in just 3 years of lives that have been saved is quite staggering. So I'd like to thank you for your contribution and for your very clear presentation. There was a lot of information in it, and I think we'll have to give people a little bit of time to sort through it and to, I think, reflect on how changes can be made in everybody's own practice. So if you don't mind, Cliff, I have one question in.
Certainly.
It's from Viviana, and her question is, did you identify any new adverse event or problem associated to the implementation?
We did identify some concerns, and I think hidden in all the data I've been giving you has been some simple things. And for instance, when we traditionally asked for charts to be designed, we assumed that everybody wrote with their right hand. And so we always put the numbers or the parameters on the y-axis on the left-hand side of the page. But if you write with your left hand, you can't see those numbers. So we had to make sure we had the numbers on the chart on both sides of the page. Pretty simple stuff. But when we talked to the staff, those people who wrote with their left hand made it quite clear that we had a problem. So when you put something out, you've got to continue to look for the unintended consequence. In our maternity units, one of the problems was that the midwives, and quite rightly, said, but our women aren't sick. And when we thought about that for a while, we said yes, but they become sick very, very quickly. So because you're on an observation chart doesn't mean you're sick. It means we're watching to make sure that you don't become sick. And very quickly, the nursing and midwifery units adopted the program. They call their chart the women at risk chart. Simple things.
Super. Thanks for that, Cliff. That's really interesting about the sort of the simple things, and I suppose it's only when you put things into practice that issues like that really emerge. Just hold on a moment. I have another question in. You mentioned stakeholder engagement. How do you engage with patients and families?
I think the first thing is to talk to them, and we had engaged with what we call in the CDC the patient-based care directorate to get their advice. And we spent some time explaining to patients, and we enlisted the support, by the way, of Warren Anderson to say, yeah, we need to know that this is an important project, we need to get behind it. And when you go onto the ward and you see the chart at the bottom of the bed, anybody can see that the observation is in the yellow zone. So we encouraged our staff in the wards to encourage the patients to speak up and ask questions. And I well remember visiting my own father-in-law who'd had a fall, and his blood pressure was in the yellow zone. And I simply said to the nurse looking after him, I noticed he's in the yellow zone, and she said that she didn't know who I was. She said, oh yes, and the doctor's coming to review that because it's in a precautionary area. So that had engaged our entire family very, very quickly. So we do need to talk to our patients. We need to listen to them and take online the lessons so we can change the program. One of the things they wanted to do was to be able to say to the staff, I think mum's not well, and not be brushed aside. And that was a critical point. It's still a problem because of the busyness that we all work under, but we are now learning to respond more appropriately to that very important trigger.
Super. Thank you, Cliff. Another question in relation to the power of stories. Can you describe how you use these stories?
I think we need to understand that as humans we're hardwired to respond to other people's circumstances if we understand the story. As clinicians, although we use data and evidence to get a compilation of things and get trends, the most powerful tool is still the individual story, preferably told by the patient themselves, or second best, told in their words, but also clinicians can tell their own stories about opportunities that they have missed. And you might recall in the NHS a few years ago, there was a book that put out, and I can't remember who actually chaired the group, but a number of senior clinicians saying where they'd failed the system. If we're prepared to admit that we've failed to recognise people in distress, we heighten the awareness for the rest of the team. You might, especially for cardiac surgery, a thing called cardiac tamponade, which is a collection of blood around the heart pressing on it, is a difficult thing to diagnose. It was only when people talked about how difficult it was and what they did to help the diagnosis that we actually started to solve that problem. So the power of stories are universal. Kids love bedtime stories. Adults love stories. That's why we go to the movies, that's why we read books. So let's use them and make the lesson very clear.
Super. Thanks, Cliff. And then one final question in from the Netherlands, where they have also introduced rapid response teams. So they're seeing less resuscitations on the normal wards, but there are still problems in using the early warning system. This is mainly due to not completely addressing all the signals, but more importantly due to the distance between doctors and nurses. Doctors do not answer the questions of the worried nurse. Is hierarchy a problem in the success of the Between the Flags program in New South Wales?
Very definitely it's a problem, and we still have an enormous divide between a junior nurse and even a junior doctor, but certainly between a junior doctor and a consultant. Another consultant says, don't call me on at home. That's still a problem. But we now, having the standard chart, we have another weapon. We can say the doctor, the patient's in the yellow zone, and they've been in the yellow zone twice, and if I do the observation again now and it's still in the yellow zone, I am obliged to call a medical emergency response team, and that data will be analysed on our database. Do you want to come in? You can do that gently. You can escalate it just as they do in the crew resource management processes in aviation and other high reliability industries. But that gradient is a real problem. The SAGO chart reduces the gradient because it puts the pressure on everybody to respond to the very obvious trigger.
Okay, thanks for that, Cliff. And one final question. Have you ever worked in a culture that allows poor engagement of patients, and how did you manage to overcome this in creating a more engaging culture at the facility level?
Could you just repeat the first part of that, please, Jane?
Have you ever worked in a culture that allows poor engagement of patients, and how did you manage to overcome this in creating a more engaging culture at the facility level?
Oh, of course we have. It happens everywhere. You know, you can be in a big hospital, a good hospital, the best hospital, but still have wards or still have teams where the patient's left off to one side. And some of the audience will have heard us talk about our patient-based care program, which I think goes one step further than the traditional patient-centered care movement, which says we address the patient when it's convenient for us to address the patient. Patient-based care says we start off with the patient. And the first thing, really very simply, is to actually do the ward round with the team around the bedside. Introduce yourself to the team, to the patient, and then ask the patient, now we're going to talk about you, have you got anything you want to add to the story? Let me give you one very quick illustration of how basic this can be. I'd been on leave, I was head of department, I came back, my colleagues were doing a ward round, and I thought the easiest way to learn about what's happening is to join the multidisciplinary ward round. We wandered along the corridor, we went into a 4-bedroom, and there was a lady there, and the registrar, the trainee, said, this is Mrs. Jones, she's had routine coronary, she's diabetic, she's had a leg wound infection, and she needs a skin graft. And I'm watching Mrs. Jones, and she's glaring, really angry, and I thought, well, I can understand that. So I went over to her, and while the team was still there, I said, Mrs. Jones, I'm Professor Hughes, I'm the head of the department, I've been away. I'm sorry to hear about all this. And she said, so am I. I'm not Mrs. Jones. You see, if we don't engage the patients, we're going to get the patients wrong, and we're going to get the patients cranky.
Thanks, Cliff. That was an excellent example. I have a few more questions in, but what I will do is I'll pop them all in an email to you, and you can get back to our participants directly, if that's okay.
I'd be very pleased to do that. I'll do it as soon as I can.
Super. Thank you very much, Cliff. So we'll wrap up there. The last issue is just of the 3 questions. And I just wanted to ask you, Cliff, had you put them into the presentation?
No, but you should have them. I did email them through.
That's great. Well, what we'll do is we'll email them out to all of our participants so they can answer them, and we'll also put them up in the fellowship forum so people can have a look at them there.
Okay, I don't think they're too difficult, but they will help to focus attention.
Super. Listen, thank you so much again, Cliff. That was a really fantastic presentation, and thank you so much for answering the questions at the end. I know it's challenging over the telephone to do it when you don't have people in front of you, but really thank you very, very much for your contribution today.
Well, thanks for Jane for organising, and thank you to the participants for listening and for asking the questions.
Super. Listen, thank you so much, Cliff, and we'll say goodbye now. All right?
Yes, thank you, everybody.
Super. Bye now.